Hello everybody, today I am going to talk to you about a case of right side infected preauricular sinuses. It is a double sinus. There were two openings present. So the second opening we accidentally discovered during the surgery. It was not very well visible. It was on the inner aspect of the helix. The main opening you can see in the preauricular region. So I have given local infiltration around the sinus and I am cannulating the sinus with a neoflon to identify the tract. So gently I am pushing the neoflon as far as it goes without resistance, and this will help me in identifying the initial part of the tract. So this is a young girl who had recurrent painful swelling in the preauricular region with pus discharge, which was treated conservatively to cure the active infection, and then I subjected her to surgery after 3 weeks. So as you can see, I am making an elliptical incision around the preauricular sinus only up to subcutaneous depth. We should not make this incision very deep, otherwise we might cut through the tract. So after making the elliptical incision, I gently dissect it with the help of sharp dissecting scissors, and then while doing that I discover the second preauricular tract, preauricular sinus. So then later on I will join both the sinuses in the deeper dissection field. So you can see that gradually I am dissecting the tract with the help of sharp dissection. One must not be very careful here not to accidentally cut through. Careful dissection is important, and so I am dissecting, elevating the subcutaneous tissue all around and then gradually trying to identify the tract. So main thing one must remember in a preauricular sinus is that sometimes it is not a single tract, and there will be multiple branches of the tract as we go deeper inside. Although the opening seen outside may be only one or two, as in this case, but inside there may be multiple ramifications of the tract, and so we have to dissect the entire infected tissue to avoid leaving behind. As you can see, some pus came out. This is from the second tract. The second opening you can see very clearly. That is the second opening, and so now I join both the openings, and this is such a rare finding because normally literature has not quoted any case, not too many cases of multiple openings on the same side. So unilateral preauricular sinus is found in 1.3% population and bilateral preauricular sinus is in 0.3% per population, but when I search the literature, multiple two or more openings on the same side is very rare. So here I found the second opening accidentally, and now I join both the openings and try to make a common, I'm trying to dissect all the infected tissue which is present, which is deep to the skin. So both the openings I have joined together, and now mostly the preauricular sinus will be attached to the helix cartilage, and that is a common finding which I have seen in all the cases I have done so far. So one must actually dissect all the soft tissue which is anterior to the helix cartilage. We have to preserve the mucoperichondrium over the cartilage, and rest of the tissue has to be removed. So I am dissecting the second tract also, as you can see, and joining both the tissues together, the first and the second, which you can see here, and dissecting all the tissue which is anterior to the helix cartilage. So this way ensures that we don't leave behind any unknown tracts which may be present in the deeper aspect. So that is the helix cartilage, and whatever tissue is anterior to that, anterior to the perichondrium, and dissecting that. So sometimes because of repeated infection, the tracts may not be clearly visible. So we must not search for the tract per se, but take out all the infected tissue subcutaneously. And the depth of the plane of dissection should be the temporalis fascia. So whatever tissue superficial to the temporalis fascia and anterior to the helix cartilage has to be removed as a complete mass. This will prevent any recurrence of the preauricular sinus. Otherwise we may leave behind some tract which can later lead to infection and formation of preauricular abscess. So now you can see that the helix cartilage has come under view very clearly, and whatever tissue is anterior to that, I'm carefully dissecting with artery forceps and also with sharp curved scissors. So while doing this dissection, one will come across the superficial temporal artery in the deeper plane, so one must be very careful while doing the dissection. But at the same time not leave behind any infected tissue which might contain some part of the preauricular tract, because it has multiple branches. It is known to have multiple branches in the deeper part. So one must take out all the branches while dissecting the tissue. So these tips which I am telling are very important to prevent any recurrence. So I have done a lot of preauricular sinus cases, and so far following this principle of dissection I have not luckily encountered any recurrence. So this technique is useful. So one must per se not search for tracts, but take out all the infected tissue en bloc with a careful dissection. So one must go to the depth of the temporalis fascia, and whatever tissue is superficial to the fascia has to be taken out. But careful dissection with cautery, bipolar forceps as we go in the deeper plane, and then slowly I am identifying the helix cartilage, very well seen now, and whatever tissue is anterior to that is being taken in the dissected specimen to prevent any recurrence. So preauricular sinus is very common, as I told you. Unilateral 1.3% incidence and bilateral 0.3% incidence has been quoted in world literature. But this is the first case I have seen which has two openings. The first opening is seen in the anterior to the helix, and the second opening was seen in the inner aspect of the helix, which I did not find in the initial examination, but while doing the surgery I accidentally discovered it, and then I dissected that also. Most common area of preauricular sinus will be the incisura, and there can be other openings also in the tragal part and also in the antitragus and also in the conchal cartilage. Multiple openings have been, various openings have been seen. Sometimes even post-oral openings have been seen which presents as a post-oral abscess rather than a preauricular abscess. So one must look out for cases which have recurrent abscesses. One must look out for these hidden openings which may not be visible on the first examination. So slowly I am dissecting the tract in the deeper plane, as you can see, with bipolar forceps and with the sharp curved scissors, and taking out the tract bit by bit. As I am doing so, the superficial temporal artery has become visible. In the deeper part you can see a bluish vessel, and that is a superficial temporal artery. One must not injure that during dissection. It lies in the superior aspect. So I have found the tract and have dissected out. What you can see, that is the tract completely excised, and that is the helix cartilage, and that deeper part you can see the superficial temporal artery. Now I am closing the wound using 3-0 vicryl after achieving hemostasis. So I close it in single layer, and I will not do any suture removal. After 1 week I will just remove the dressing. I do a pressure dressing to prevent any collection in the dead space. So interrupted sutures with 3-0 vicryl are done, and then followed by a mastoid dressing, which I remove after 1 week, and the wound heals very well. So this is the commonest area of the preauricular sinus, and if it is getting recurrently infected, one must do a complete excision. So this is the closure. I do a pressure dressing over that for 1 week and give oral antibiotics, and this is the healed wound after 1 month. Thank you for watching.